Right, so we'll now move on to the response to the recommendations made by Dr. Kirkup. Ian, are you going to lead us through this?
Yes, I shall. And clearly this is in stark juxtaposition to it's great to hear about good leadership and the impact that that had at Princess Alexandra. This clearly is not a similar situation. I should start, I think, by, if the board will indulge me, just reading out the first paragraph 1.1 from Dr. Bill Kirkup's report, because I think it sets the context to which we will then need to respond. It goes to say that Liverpool Community Health NHS Trust was a dysfunctional organisation from the outset. The Trust acted inappropriately in pursuit of Foundation Trust status, setting infeasible financial targets that damaged patient services. The Trust managed services that it was ill-equipped to deal with, particularly prison healthcare in HMP Liverpool. Senior leadership and the board failed to realise that the Trust was out of its depth and did not take heed of the effects. Staff were overstretched, demoralised and in some cases bullied. Significant unnecessary harm occurred to patients. External bodies, that includes the North West Strategic Health Authority, commissioners and the forerunners to this organisation, amongst others, failed to pick up the problems for 4 years. So the report, I think, is a searing indictment of what happened in Liverpool. I think we've all read the report. I've engaged personally with Dr. Kirkup to discuss the report's conclusions and recommendations and sharing with him our intended response to it. And I think what I want to do now is set out our response to the very serious concerns raised by Dr. Kirkup's report. I should say it sits alongside the independent investigation that is referred to in paragraph 3 of my report, which continues. So this is focusing on very much the actions that I think we, either as NHS Improvement or in some cases working with and in support of other agencies, need to undertake to make sure that the situations and the failures that were outlined in Dr. Kirkup's report do not happen again. So you will see that the recommendations are multifaceted. I'll just highlight briefly the key recommendations. Recommendation 1, Dr. Kirkup suggests that in approving trust board appointments, NHS Improvement should take note of the level of experience of appointees, the level of risk in the trust, and should ensure a system of support and mentorship for board members where indicated. And I think it's really important for us around this table to reflect upon the fact that NHS Improvement has a statutory role in appointing chairs and non-executive directors to NHS trust boards, that we don't have a statutory role in relation to any board appointments to foundation trusts, either executive or non-executives. And while we're heavily engaged in the often in the executive appointment process in NHS Trust, we have no statutory role, but we're clearly heavily involved. And I think the conclusion of that and the importance that we've heard about in a couple of different examples today to making sure that good leadership and experienced leadership we know links to good quality care is that I think our role is insufficiently clear. And therefore I'm intending that we review and codify our oversight and support arrangements for both executives and non-executives across the whole of the provider landscape. And my intent, which I've discussed with Dr. Kirkup, is that we then bring a report back in May 18 to this board. I intend to talk about how we chase progress and make sure the recommendations are taken forward. But I think we need to seriously look at the extent to which we support the 232 organisations out there with their leadership and make sure that that is appropriate and picks up on the report. More generally, you'll see in para 14 and beyond, we need to do absolutely consider our role in relation to the development, support and management of leadership and talent across the NHS as a whole. I believe, and I intend to bring forward proposals for the need for a proper nationwide system of talent management for NHS organisations. I think the fact that we are the regulator for the provider sector that oversees the care to patients across the country means that we have, I think, a really important role to play in supporting, developing and managing talent. I think we also have a really important role in supporting the rehabilitation of individuals who may have had performance issues but who nonetheless have a valuable role to play in the NHS going forward. And I think we also need, therefore, to recognise that we need to be able to distinguish the situations in which it may no longer be appropriate for an individual to work within the NHS, and to distinguish those two things more clearly. And I know, for instance, one of the issues that inevitably gets asked is about a perceived revolving door. And so I think in overseeing talent, we have to address those issues as well. I think the consequential for that is listed in the action for recommendation 1, that I believe that we need to work with other national bodies, absolutely including Health Education England and the Leadership Academy, but to develop an ambitious talent management and professional development officer for the whole provider sector across the country. It's a big enterprise. I think it's implicit in the Kirkup report that this will support the development of quality care, and therefore I think as the effective headquarters function for the provider sector, if we can describe ourselves as that, I think that's an important piece of work, a big piece of work. And so my commitment would be, or my suggestion would be, that we work with other agencies to present a really ambitious talent offer, together with the details of how we would operationalise that, and bring some ideas back to the May board on how we would take that forward. So I think there's a lot of work to do in relation to recommendation 1. In recommendation 2, talks about assessing the level of risk facing an individual trust, and makes the point that this is about the cumulative impact of relative factors, including where organisations are new or inexperienced, where they have inexperienced boards, challenging cost improvement targets, or changes in organisational structure, maybe linked with service acquisitions. I think this is particularly relevant, seeing that Dr. Kirkup's report found that, as I mentioned earlier, national and regional NHS organisations failed to fully recognise the level of risk facing Liverpool Community Hospitals, Liverpool Community Trust, from 2010 to 2014. A situation, I think, which none of the organisations concerned would have wanted to be party to. So I think while we can see that, I think since 2014, NHS Improvement, the CQC, and NHS England have actually established, I think, quite a wide range of new approaches that make the likelihood of another set of care failings, such as Liverpool, significantly less likely, and they are listed in paragraph 18. I think that is not sufficient reassurance for us that we don't need to test those. And so the recommendation in paragraph 19 suggests that we will work with other national organisations to stress test the current oversight approach that we have against a range of scenarios, just in the same way as other institutions stress test their mechanisms. I think we need to do that, and we need to do that across the summer, so that we're confident that we can collectively identify risk in a way that is significantly better than was the case prior to 2014. Specifically in relation to cost improvement targets, Dr. Kirkup identified that the pursuance of unfeasible financial targets was damaging to patient care. Clearly, since then, it's very clear that provider boards have the primary responsibility, necessarily, for the creation and oversight and implementation of their cost improvement plans. And it's really important that medical directors and chief nurses engage very strongly in a quality impact assessment of those plans. So the primary responsibility necessarily sits with the board. However, I think there's also a challenge to us as the sector overseer to make sure that based on our judgment of organisational risk, we seek additional assurance over cost improvement plans as to their robustness and their clinically led nature, where that is perceived as necessary. And so I think particularly when we consider plans for this year, I take nothing away from the primary responsibility that sits with boards. That's absolutely where clinical and managerial leadership needs to come together. Nonetheless, we have a role, I think, in making sure that we have an effective oversight of that. And so there's work for us to do there. Moving along, recommendation 3 talks about the use of information and soft intelligence and making sure that that is more effective than was the case back with Liverpool Community Health. And you will see in paragraph 23 that we are developing work in a number of areas. We have developed work. So NHS Improvement and the CQC now work together, I think, much more closely in areas such as use of resources and well-led assessments. We've got quality surveillance groups at a regional and a local level to bring together oversight and triangulate and share quality and performance information. And we've got a joint strategic oversight group at national level to support and do the same. So I think, again, there's a lot been done. But I think, and it's relevant to our work with NHS England that I think I talked about earlier, one of the things that we absolutely need to engender is a sense that as we work more closely with NHS England, we're able to speak to and support local systems with one voice and to streamline and make clearer the oversight and support that we provide. I think that really needs to be built into the joint work that we're undertaking with NHS England, and it will be. I'll be intending to bring further updates on that back to the board in May. Recommendation 4 talks about the effect of making sure that regulators and oversight organisations should ensure that both during national and local reorganisations and reconfiguration, performance and other service information is properly recorded and communicated to successor organisations. And this relates to the finding in the Kirkup report that in, I think it was January 2013, the handover information from the former North West Strategic Health Authority to the Trust Development Authority didn't get to the issues that were going on in Liverpool Community Health, and clearly that's really important. So I think there is a real mechanism here for us to work with NHS England to make sure that we have a much more integrated approach to regional oversight, and we're thinking very carefully about how we support the NHS in regions so that we're closer to where the clinical action is. I think in addition to that, we will need to absolutely review our own standard operating procedures to make sure that our own regulatory support committees ensure information is collected and codified in relation to any changes that we're ourselves going through potentially in the future. So I think we've more work to do there. And then in addition to that extensive programme of work that I've outlined there, really, if you think about the magnitude of that, that is a significant programme of work. We also need to pick up on several recommendations that Dr. Kirkup has made specifically in relation to Liverpool Community Health services and staff. And they're listed at 6, 7 and 8. And I've discussed these again in detail with Dr. Kirkup, and I think it's really important that they're all actioned. So they include making sure that all the organisations taking on the former Liverpool Community Health Services should go back and review the handling of previous serious incidents to ensure that they've been properly investigated and lessons learnt. And I've agreed with Dr. Kirkup and the organisations that are the current providers that these reviews must be handled with an appropriate degree of independence and openness in order to assure patients, families and staff these matters are being dealt with seriously and thoroughly. I think that has been agreed that will happen. That organisations taking on former LCH staff as part of service transfers should review the handling of disciplinary and whistleblowing cases urgently to ensure that they've been properly and appropriately resolved. And importantly, that organisations should ensure that staff are not placed back into working relationships previously that are subject to bullying and harassment. I've agreed with the provider that has to date taken on most of the former LCH staff that an independent practitioner will undertake a review of whistleblowing records, and that an independent HR practitioner will review disciplinary investigations. We're going to be asking all the other organisations that are involved in taking services to take a similarly robust and independent line to those recommendations too. And then finally, in relation to making sure that things work in Liverpool for patients going forward, Dr. Kirkup recommends that after 1 year, by which I read March 2019, there is a review of the services formerly provided by Liverpool Community Health to make sure that they are both safe and effective. And we have agreed that using the joint quality oversight infrastructure that has taken place since the report, that this will be done. And I'm committed that those results are then published so that the public can be assured of the safety and efficacy of the services, and we have that intent to work with local services as well as our colleagues in other bits of the infrastructure to make sure that that's carried out as well. So I think in conclusion, it's really clear to me that the events described in Dr. Kirkup's report should never have happened. They should have been found earlier. And while things have moved on significantly, genuinely, I think significantly, since those days in the NHS, and I think the recurrence is in some ways made far less likely by the way the NHS has moved and developed at local, regional and national level since then, there are a significant range of pieces of work that we ourselves need to do, and we need to support the NHS need to do, and we need to work with other national organisations to do, to make sure that we respond to the concerns raised. And I think that's what I'd like to discuss with the board.
Thanks, Ian. Questions? Sarah?
Well, a comment more than a question. My recollection, because I was sitting on a Strategic Health Authority in 2010 when this will have been created, it was an initiative called the Transforming Community Services. We had a deadline to create new organisations, to spin services out of what were then primary care trusts into new organisations. All of those types of processes start with a very clear focus on, obviously we're going to get the quality right, we're going to check these organisations are sustainable. The closer you get to a deadline by which all these organisations have to be up and running, the easier it is just to shove things over the line and boxes get ticked. And I suspect this is what happened here. We're now in the middle of another process of looking at reorganisation of services and organisational form, and I would just raise the caution that we don't get caught up in the same merry-go-round again of we've got to get it all done by a certain date. So let's just make sure we don't do it again, because I think that's what happened there.
Yeah, absolutely right. Sigurd?
I was just... So much of this reminds me of a discussion we had around the then monitor board table when mid-staffs blew up. And one of the things we ended up concluding at the time was that although it came as a surprise to lots of people, there were also an awful lot of people who were not surprised, because it was widely known locally that there were problems. And we resolved, you may recall this, Stephen, that we would try to do a much better job of accessing soft intelligence. You alluded to it in your comment, but if you look at paragraph 23, there isn't actually anything there that's soft. And by soft I mean sort of just making sure that our own folk out in the regions access people like local MPs, local councillors, because if people have a worry about their relatives or whoever, that's where they go. And so that's a really good tripwire, a really good early warning system. We need to add that to our armoury.
Yeah, I completely agree.
I mean, the same was true of Morecambe Bay.
Yes, exactly.
I remember that.
Yeah.
In fact, Bill did the review there as well. And I never forget a number of the MPs said, well,
Yeah.
We always knew there was a problem
Yeah.
there, but the systems we had in place, as you
Didn't
said,
pick it up.
didn't pick it up.
Yeah.
I suppose that there's another point for me, and I'm glad you raised mid-staffs, is that actually some of the findings are not dissimilar to
No,
mid-staffs,
no.
and therefore there is a question as to, given the amount of work that went into implementing those recommendations, why we haven't been more successful in preventing this.
Yeah.
Can I just reinforce that as well? Because when I read through this, it was like another version of mid-staffs.
Yeah,
Now,
yeah.
the first Francis report was 2010, which is the start of the period we're talking about here. So, and it may well be when we look at all this here and follow through on all the actions, we will get a view on, well, why, given what had happened in mid-staffs, and that was so fresh in everyone's mind in 2010. 11, whether it was us, the Department of Health, CQC, everybody had mid-staff at front of mind. But we still had this happen. Now, it may be, and this may be one of the things we need to think about, this wasn't in an acute hospital setting. And our issue is, in responding to mid-staffs, the focus was on acute hospital settings. And we had other stuff in mental health settings around the Southern Health stuff. We've had stuff in community settings. And there's a little bit there about have we paid enough attention to this bit. The other thing that actually comes through really strongly, again, it's very clear, I think, with mid-staffs, is about, it's not just people outside you, people inside you. There's stuff here about a bullying culture, about sort of suppression of whistleblowing, poor HR practices. And one of the questions I keep asking myself is why we don't focus as much on the HR profession as we do on, we get obsessed about nursing directors, medical directors, chief executives, finance directors. We hardly ever have any conversation about the HR profession, the HR leadership within our organisations. And it's just something I think we maybe should reflect on as a board about where is that focus on HR in this organisation.
People management and
Yeah.
people leadership.
Apart from we think about it with the chief exec and the medical director and the nursing director, but not that professional HR side of things.
Yes, so I agree with everything that has been said there, and I think Ruth and I were talking about Richard's point, really, the community hospitals or non-acute. But what I think one of the big things for me with all of this is that we need to make sure we never ever become complacent. We never ever think we've got things in place, because I think that this is a demonstration of how you simply don't have necessarily. Now, looking into where we are now, and in the paper, you've referenced a few things, Ian, there that are now in place. So not just, I think that CQC is a stronger organisation than it was pre-2013 in terms of the way it inspects, but we've got the freedom to speak up guide, and we've got that process around the speaking up, which kind of plays to the point that was made about the local soft intelligence. And I think that over and above all of this, there's a huge lesson, I think, for us all. When people speak up, there's something to find, and assume that they're telling you something, rather than, well, it was only one person, or it was only two, or they were at different times, or something. So I think there are massive lessons for us here. You have to hope that going forward we can implement all these things. I do actually think that there is more in place now than there was, but the complacency piece is, and I think Ruth and I were talking about, we probably need to do something more on community trusts anyway, because we don't have the data, we don't have the information in the way that we would with an acute. So I think there is something very particular about those, possibly drawing in mental health as well. But I think that's something that is almost an additional action that we would want to take to look at that. You didn't speak to it as you talked,
I didn't.
but there is an action.
There is, and I think I would support what Kathy has said. I think there is an action now that's currently underway to conduct a rapid review on the level of experience and risk in community trusts, which I think is being conducted as we speak. But I think more generally, the point that Kathy makes is right. There's a massive importance of community services. They're looking after very vulnerable patients in community settings, and I think we do absolutely need to have a look specifically at community services from both a quality and an output perspective. I think that work would be really important, and I know there's some work planned on that.
Pat?
2 points, if I may, Chair. The first is that it would be acutely embarrassing if another one of these occurs whilst we put these processes in place. And we talk about soft intelligence. I mean, it's curious to me that we have a massive structure. We're paying lots of people out there in regions. We're paying lots and lots of people. And yet we were surprised. And we've had a number of surprises, some not as bad as this. But personally, I don't like being surprised. I don't think any of us do. And I would just request that the management does go backwards over all the organisations now we have out there now, and do a dipstick and find out if there's anything we should be worried about. Because as a board, this would be acutely embarrassing if another one of these comes along and the processes to stop it aren't yet in place. So the only thing we've got is soft. We don't have data for some of these things. Soft. I just would be more comfortable if we're able to do that. And I think it comes then to the point that was being made that because often our mental health trusts and our community trusts are in aggregate in significant deficit, the question is this a problem the other way? Are people underspending, as we saw in the case of Liverpool? You know, it's as serious a problem. And
Yes.
I think we come back to the question of how much attention at the senior level we're giving to those two important sectors. And I just, again...
I agree.
Ruth and then Sarah.
Absolutely, Lord Carter. That was the conversation that Kathy and I had over the last 48 hours or so about how we look at all of our sectors rather than just where we tend to want to look. My 2 points was I remember being on the board of an SHA when presenting the mid-staff's paper when it came out. And actually there was an awful lot of resource we need to collectively put behind the follow-through. And I think we need to consider whether we've got enough resource people, our personal time on making sure that we follow through these actions, because the actions you've put forward in is perfectly fine, but we now need to deliver on them when we say we deliver on them. And that's going to be important for the confidence of our professional people that we lead, but also the public and patients. And then finally, there is also something about how, like Elizabeth said, we actually lift more and more of our eyes and ears on the ground. I know we spend quite a lot of that time visiting organisations, but what this does for me is to reprioritise my diary yet again to think, how do I get out even more to visit these organisations, because it's only by listening, seeing, feeling, touching an organisation that you can start to see this.
Sarah and then Sigurd.
A question, if we're doing a review of indicators, things that we might have missed, one of the things that happened when there were SHAs were regular serious untoward incident reviews, which happened when there'd been a mental health homicide, for example, which were investigated to a timetable and came to the board. That seems to have been lost. I don't know whether they are still being done or whether they get done publicly. But for a regional, it was quite clear, well, that's another serious incident in this hospital, that mental health trust or whatever. It was a more visible flag, and I think we've lost that visibility. I don't know where that information sits now.
Kathy?
So serious incidents obviously are absolutely reported through STICE and through the NRLS and so on, and they come into the patient safety team. Where there are things that are themes or whatever, they send out patient safety alerts. And then there's the quality surveillance groups which are mentioned in the paper there and that sort of thing. I do think there is a point though that you are making, that in terms of where does it actually come together more systematically. I think that is an issue, and one that Ruth and I are concerned about, because things go up different routes, and has anybody got an overview? So we see, for example, all the never events that happen in any week, they are reported to us. So we see what's happening. But in terms of where do we then bring that together to say, well, what's overall happening? Our team does publish something every so often, but I don't think it's quite the same as in the days of an SHO. Not I'm saying that that was perfect,
No, it
but
wasn't, but
there
some
was
areas-
somewhere that you could take an overview. And I think in amongst all of this, we need to reflect on, and perhaps in some of the work we're doing in trying to work more closely with NHSI,
That's
that we can bring that
that's
Yes.
into a more powerful place and take action rather than observe what's happening on the river going by, really.
Yeah,
which
I
is,
agree with
you
you,
can get
Cathy.
into that place. I think we need to be far more proactive and confident to do that, really.
Sigurd?
It was just a thought that came to me as I was listening to this, and it reinforces something I think Ruth said. At the root of much of this, when it happens, and it was certainly the case with mid-staffs, and probably here too, is bad culture, bad attitudes, which have taken root. In this case, it sounds like it might have been the entire trust, but often it's been pockets within. And maybe the difference with community trusts is that so much of what happens there happens in a decentralised way, out and about, and we may therefore, as we set about equipping ourselves with better ways of detecting it, make sure that we don't just look at the centre, but actually get a feel for what happens, and perhaps include ambulance trusts in that too, because one of the striking things about ambulance trusts is that you can have very different cultures in different localities, and it's palpable. It's as Ruth says, when you go and visit somewhere, you can almost smell it. You really need to get out there, down at that level. So it was just a thought I wanted to share with everybody.
Elizabeth?
It's just something that Pat said and something that I'm starting to perhaps experience in terms of board appointments. I think that we need to think about not only new appointments, I think we need to think about the resilience of individuals. So the environment's changed. So at one point in time, someone could have been perfectly adequate to do a certain role and be able to fulfil their role. But I've just started to think about, how we support the people that are already in the jobs, because the environment has changed just so dramatically.
Yes.
And they could slip through the net because they're not a new appointment.
Yeah. Ian, you were wanting to...
No, I think the moment has passed.
Okay. So I think for me the summary of this is that this is a really very serious moment for us as an organisation, that we do have to look at ourselves in the mirror and feel some responsibility for not, the organisations that we've inherited, for not actually acting faster. If we had, things would have been different. And so we've got to make sure, to Ruth's point, that we're marshalling enough resource to build the action plan. I think there are some really very material actions in here, as you've said, that are huge, actually at the core of our operating model, of what we do. And the danger is that they can be interpreted in two ways. At the worst case, as a sort of, just tick a few boxes and carry on doing what we're doing. I know that isn't the intent of the executive at all, but we just need to make sure that you've got sufficient focus so that when we come back in May, we really have got a route and a clear set of actions and people assigned to them, so that over the course of the next 6 to 9 months we have genuinely moved the dial.
And that's my
That's the
intent,
challenge.
really, as we move forward, because I think your words are absolutely right. My aim is to bring a further report back in May, and so we can then continue to track the progress on moving ahead
Okay.
at the scale and in the depth
Yep.
that is necessary to make
Yep.
this reality.
Because there's some very urgent actions, as Pat's articulated, in terms of making sure that we are not just looking at community trusts, but across all of our trusts, checking for warning signs that we might not have checked for in the past, because we really don't want to be caught out while we're implementing more fundamental actions. And then there is the real fundamentals around how we identify, support, develop and challenge the leadership in trusts and genuinely play our role in the region and at the national level to do that.
Completely agree.
Okay. Anything else on that? Okay.